So I'd like to talk about management of burns with dressings and antiseptics. And the main focus of this talk is very factual, and I'm sorry, it's rather a dry talk in comparison with the kind of talks that I like to give, which usually have lots of pictures and show lots of operations. And for a surgical audience, I'm sorry the talk is slightly dry. So what I've done is I've arranged for a PDF of all the slides to be made available to everyone who participates by email. And I hope the organizer, I just sent that to the organizers at the last minute, and my apologies to them for giving them that task at the last minute, but I think they're able to do that for you. So I will cruise quickly through some of the slides so as not to make it too tedious for you. So first of all, starting about the lessons of history, and there are many descriptions of dressings and antiseptics which were identified and used even from ancient times. And for example, the Egyptians, Greeks, Indians, and Romans, or various more civilized antecedents, used these different substances in treatment of burns. And I just want to emphasize from that list, for example, honey and vinegar for use as antiseptics, lint, which is obviously cotton type gauze for main dressings, and oil to prevent adherence of dressings. So those are the sort of fundamentals of things that we use for burns dressings today. And another lesson from the Romans was they described these 4 cardinal signs of infection in association with wounds or other problems: redness, swelling, heat, and pain. And of course, we should add to those, to that, those four cardinal signs that the Romans described: smell and discharge, to our assessment of wounds. And I'll revisit that a little bit more later in the talk. And very close to my heart is the work of Lister, who was based in Glasgow Royal Infirmary, where our Canisburn Burns unit was, when he did his pioneering work with carbolic acid, which is obviously too toxic a material to use on burns, but the use of antisepsis within our world revolutionized the history of surgery, which till that point had been a very septic enterprise, and people in developed Europe had lost sight of the fact that the ancient lessons from Egypt, India, Greece about antisepsis, and they undertook surgery and looked after patients without appropriate antiseptic precautions. So Lister's work changed all of that. And around the same time, Robert Wood Johnson, who was one of the first, the developers of the company Johnson & Johnson, produced gauze and wound dressings impregnated with iodine, which remain widely used today and are a mainstay around the world. And in terms of the history of wound healing research, there was a contrary bit of research much more recently, which showed that moist wounds healed faster because of improved epithelialization. And that is a feature of some of the dressings regimes. So just to go through some of the basics in terms of terminology, primary dressing is the one that's in contact with the wound, and the secondary dressing is that which retains the primary dressing in place, and it has to have various features which include absorbency and prevention of infection. These are some of the characteristics of the ideal wound dressing, which you see listed, and I won't read through all of these. I'll just leave this there for 20 or 30 seconds so that people can look at it. But what we're trying to think of when we treat burn wounds is putting something on the wound that doesn't interfere with healing, that prevents infection, and that is comfortable to the patient. But at the bottom there, and I think the emphasis of this talk, which is for services all around the world that are limited by resource constraints, is that it should be cost effective. And that is what I've tried to identify from some of the topics within this talk, is ways of identifying cost effectiveness within dressings, whilst at the same time I've included not an exhaustive but a very extensive list of the types of dressings which are available for burns. Specific to burns should be things like they need to be highly absorbable for major burns, and they need to prevent infection for major burns. And they should be available in suitable forms and sizes. So again, I won't read through all of this, but I'll just pause enough time so that you can look at it. So this is a key slide really in terms of the principles of burn wound care management. And again, I'll just give you time to read it rather than reading it through myself. But things that are important here are the debridement process, which particularly for people working in resource limited settings where patients commonly come with contaminated wounds late after the injuries, is hugely important. And I'll discuss that a bit further. Microbiology is hugely important, and topical antiseptics are generally a mainstay of the management of wounds and burns. And that is a difference from management of many other wounds. Topical antiseptics aren't always necessary in trauma wounds or surgical wounds, but in burns, infection is the greatest killer of burns patients around the world. And it's widely accepted that we do use topical antiseptics with our burns wounds. So in terms of debridement, here's a very simple example of debridement, which is cleansing of the wound of debris before the dressing is applied. And you can see this is one which has been done on a small wound with minimal analgesia or anesthesia, and the cleansing is relatively limited, and that's suitable for small wounds. But when you have much larger wounds that are life-threatening, the debridement should be much more rigorous. And the fundamental background to that is that it's important that the patient is given enough analgesia or anesthesia, particularly anesthesia for children, to give a really good cleaning of the wounds. And for example, in limited resource settings, anesthetics such as ketamine can be very useful for this. But many burns units around the world, even in limited resource settings, the most important thing which can improve wound management is often if there is good anesthesia in terms of providing analgesia and anesthetic to really properly clean a wound. And in this case, you see it's getting all the dead epithelium off the surface of a superficial wound. The same will apply for a flame burn where there's lots of carbon, bits of clothing, and commonly in many settings, lots of dirt. So it's vital to clean things up as much as possible. And for continuity with this patient, this child, applying then antimicrobials to the surface of the wound is very useful and commonly very important all around the world. And this is one example of silvadine or flamazine, which is silver sulfadiazine, which has been widely used for a long time. And the main disadvantage of it is that it changes the wound appearance for assessment. So here's an example of a debridement which has not been done well. And you can see how this person's actually had escharotomies, but there's lots and lots of dead skin around. And that's not what you want to see. So the process should have been in managing this person's hand, that all this was cleaned up before the escharotomy, because the escharotomy is actually a time when it's a portal for infection to get into the person's body. So actually, things in this particular person's case have been done the wrong way around. There's been a hurry to do the escharotomies, and lots of dead skin and debris, with all the potential for bacterial contamination that has been left behind. So a vital component of the start of wound management with dressings is cleansing, if necessary, scrubbing of the wound, perhaps showering of the patient, and then early on after the injury, frequent dressings to clean the wound up. One of the problems with use of seeking the ideal dressing for a burn wound is that it does not really exist, because the biggest constraint is cost in terms of the size of the wounds. Really, wherever you're working in the world, there are a small number of exceptions to that. But because of cost, that means we tend in burns patients to use fairly simple methods for dressing wounds. And for that reason, rather than using complex, expensive antiseptic dressings that can be left in place for prolonged periods, we need to think more about changing the simple dressings that we use fairly often. And there are a variety of reasons for this. But the most important reasons are that frequent changing keeps the wound clean and it further debrides it. So if you have a burn wound, particularly, for example, in a patient who's come late after the injury that's contaminated, infected, if you have the resources in terms of staffing, which many units do, changing the dressing often in the early stages is a good way to get it clean. The disadvantages of this is it's more pain for the patient and it's labor intensive, but it is a fundamental principle when you're using simple dressings of getting the wound cleaned. Infrequent dressings can be used when you have high-tech silver-containing dressings, for example, but those are not widely available around the world. And if you change dressings infrequently, then you have a higher risk of infection. So how often should we change the dressings? Well, most often when the patient first comes in, we change them each day to remove the exudate soaked dressings that you see early on, and also to observe and to diagnose the depth of the wound. But then once the patient is established, a general compromise is that we change the dressings every 2 days. But a rational strategy that can apply the timing of how often you change the dressings also depends on the depths of the wound and whether the wound is clean or contaminated or infected. So, for example, if you have clean dermal depth burns, particularly superficial dermal burns, if you go through a period of changing them every day initially, then you can change them less often, particularly if you have suitable antiseptic dressings and you're confident that the patient is well, and this will encourage epithelialization. Because if the dressings change too often, it's painful for the patient and it impairs epithelialization by tearing away the new epithelium that's healing. But you have to be confident that the patient is well to do this. So the key thing is clean dermal depth burns. Aim to change the dressings less often. For full thickness burns, then the risk of infection is much higher and there's less pain. So after the initial few days, changing these every 2 days with antiseptics contained, and also showering and bathing to further debride the wounds is a rational strategy, because the main issue for full thickness burns is infection. And you're racing against time to get the patient healed before infection kills them. So contrary to those with dermal depth burns that are likely to heal themselves, if you have full thickness burns, then being more rigorous about changing the dressings regularly to prevent infection is important. So the balance with full thickness burns is more in favor of changing the dressing slightly more often and not leaving the wounds alone. But if you have infected or contaminated burns, then it's worth considering using daily dressing changes to physically debride the wound and to reduce colonization, to reduce the risk of infection. And that's a way of actively continuing the debridement process more rigorously by more frequently changing the dressings. And also in an infected or contaminated wound, you would use focused antimicrobials, and the focus will depend on the microbiology, perhaps, if you have access to that, or to the observation of the wound. So if it's early after the injury and you see golden purulent exudate, you might think it would be a staphylococcus. If it's later and you see a green exudate, you think it's Pseudomonas. So topical antiseptics will be used if you have infected or contaminated burns quite rigorously and in trying to use them in quite a focused way. And also, if the patient's unwell, systemic antibiotic therapy will also be used. And the process of wound observation for the whole team is hugely important. And this is where educating the whole team, the nurses, even the therapists, and all the doctors to note the signs of wound infection, burn infection, and to act on them is hugely important. And in many services, this does remain a problem, but it's the cornerstone of preempting problems rather than having a patient who gets a severe systemic infection and is overwhelmed by it and dies. So looking out for these different signs, and many units will have structured observation charts where these things can be recorded. And the key things go back to the Romans' description of these 4 cardinal signs, but also the smell of the wounds and the appearance of the exudate. If the volume of the exudate increases, if the exudate is discolored, systemic condition of the patient for signs of infection is hugely important, and wound microbiology, whether it's wound swabs or biopsies, is hugely important. And in the best resourced units, there will be regular wound swabs sent as a matter of routine. This isn't always available around the world, but if you can base your interventions on wound microbiology, that's important. And also knowing the microbiology of the unit at any given time is important, because there will tend to be cross-infection within the unit. Finally, necrosis is a very important, more rare sign, but here's an example of progression to necrosis in a burn wound, which is a very bad sign and typical of invasive infection. And this would be an indication in a wound that has changed like that, from being a dermal depth wound with a central slightly deeper area to being a necrotic area. That is a bad sign and will demand more frequent dressings changes, probably systemic antibiotics, and possibly a wound excision. So I'd now like to talk through various types of burns dressings and antiseptics. And just to start with simple things, but these are all the things that we're going to cover. I won't read through all of this. But gauzes are by far our most readily available simple wound dressings. And these are the features of gauzes. Again, I won't talk through all this. I'll just give you time to look at this. The key things about use of gauzes are that they absorb exudate and they are used for covering the wounds. They can also are invaluable as a carrier for antiseptics, because you can soak the base layer of the gauze, and that's just fundamental to our principles of how we treat wounds. And they control exudate. And this is a typical issue where exudate goes through the dressings, what's called strike through. And strike through is always a risk for the patient because you have a far greater risk of bacterial ingress through the dressings because of capillary action through the fluid. And also it's a reflection of the fact that the dressing is soggy and it's becoming a great culture medium. But the most important thing about exudate seeking through dressings like that is that it facilitates bacteria moving in through the dressing. So what we try to do is to avoid this appearance as much as we can. And when this occurs, either repad the dressing with a sterile gauze on the outside, or we change the dressing. A very good way of repadding and putting in outer layers to prevent this strike-through phenomenon is the Ganji wool and gauze dressing, which we use widely in our own practice in UK. Another thing that's very important, probably one of the simplest, most important things for use in burn services around the world, is to have sufficient sized and volume burn swabs. So this is the size of burn swabs that we use in our service. And there you see it against my hand. And if you can source these, they're relatively cheap. They're relatively easy to make. They need to be sterilized, obviously, but they're the mainstay of actually providing dressings for the typical burn service. There's nothing worse to go to dress a major burn wound and have to put on hundreds and hundreds of tiny gauze swabs. Also, it's better to use large sheets of gauze like this rather than the gauze roll. Because if you use the gauze roll close to the surface of the wound and you don't split it, you have a much greater risk of, when that dressing gets wet and then dries, of getting a constricting tight dressing that can cause localized tissue ischemia and even compartment syndrome. And that is an unfortunate problem in really low resource burn services, where they wrap gauze round and round the limbs, it gets wet and then it dries and acts as a tourniquet on the limb. So using large gauze sheets reduces the risk of that problem. So please excuse me, everyone who's listening, who knows a lot about burns, if this is very simple, but these are fundamental principles. So I want to talk now about antiseptics used along with gauze to reduce colonization of the burn wounds and to protect the burn patient from infection. And the most important thing about antiseptics is it's crucial to use the correct concentration. And so, for example, household bleach can cause skin burns, contains sodium hypochlorite at 5% concentration approximately. Dakin's solution, which is widely used for cleansing wounds, contains sodium hypochlorite at less than 0.5%. And there's excellent research which shows that 0.025% sodium hypochlorite is a useful burn wound antiseptic which does not interfere with wound healing. So, for example, when I talk to what I regard as one of the best burns units in the UK, the unit in Chelmsford, about what they use on antiseptics on burn wounds, a common thing that they would use is simple 0.05% sodium hypochlorite, which is an excellent antiseptic. And here's a reference from the Galveston unit from 30 years ago about use of sodium hypochlorite solutions. So for those working in limited resource settings, but also in high resource settings, simple antiseptics such as sodium hypochlorite can be very, very useful. Iodine is another mainstay of use around the world, and it can be used in a variety of strengths. And the evidence is that iodine causes minimal or no impairment to wound healing. So it's aqueous, always important to use aqueous rather than alcohol solutions or the soap solutions. And it can be used in percentages such as 1% or 5% usefully on wounds. Evidence is that at the low strengths, it causes minimal or no impairment to wound healing. Disadvantages of iodine are that it has a short duration of action and it's less active against Pseudomonas. And it can also cause these other issues, particularly theoretically can cause thyroid problems if used on extensive open wounds. I think at this point, we'll just pause for a second and look at any of the questions.
Yeah, so we've got a few questions in the chat. The first one was, can we delay, this is from Mohammed, can we delay debridement for later, like in second or third dressings, rather than doing it on presentation, only asking for clean wounds like a scald burn?
Yes, definitely. And that's very appropriate to children where the anesthesia may not be available at the outset. So doing a planned debridement 24 hours later, if necessary, is a very good idea from the point of view of the analgesia, if your anesthesia is not available initially. Yes.
Okay. Dr. Sonale, what is the use of infrared light as a treatment for burn wound management? Will it dry the wound without infection and decrease exudation from exposed wound?
That's a very interesting question, Dr. Sonale. We have used not infrared light, but a variant on ultraviolet light called high intensity narrow spectrum light for decontaminating the environment in burns, and we published on that, and it's actually very useful. And certainly ultraviolet light is quite bactericidal. I'm sorry, I'm not sure. I don't know about infrared. I don't know. Tony Barabbas is also on the talk. Do you know about infrared, Tony?
No, I'm afraid I couldn't comment on that. I wouldn't know.
The other thing for Dr. Sonali is if you're asking just about exposure to light generally, then some people feel that exposure treatment for difficult burn wounds is a good way to, because you dry the wound, you kill infection. And that is a line of management, but you need a very sterile environment to do that. And that it's become less popular before that. Kiran Nakarmi, I'm going to talk about donor sites later. So Kiran, I'll answer your question later about donor sites. And gauze roll bandages, Kiran, we use crepe bandages. And the disadvantage of gauze roll bandages is that they are inelastic and they do get very tight. So generally speaking, we avoid using gauze roll bandages if we can because of the inflexibility. And very good question from Alexandru Sebastiantino. Is betadine cytotoxic for wound healing? It remains controversial, but the weight of evidence, Alexandru, is that lower concentrations of betadine, such as 1%, are non-toxic for wound healing. So I think it is pretty safe to have a low concentration of iodine from the wound healing point of view. So other questions there. Thanks for Dr. Cabral for his point about if everyone just reads in the Q&A. So I'm going to go back and continue the talk because some of the other questions will be answered later. So moving on to antiseptics, widely used around the world is silver sulfadiazine, so known as Silvadine or Flamazine. Has a very broad spectrum, is soothing for the patient, easy to use. One disadvantage is it makes diagnosis of depth of the burn more difficult, but it's a very, very good antiseptic as a mainstay antiseptic if you have it available. In limited resource settings, it's relatively more expensive, for example, than iodine, and accordingly, it is probably one that you would save for particular cases in a limited resource setting, but definitely a very, very good antiseptic. So moving on, there's a question about Pseudomonas, and going back to the ancient Greeks and ancient India, vinegar was widely used for cleansing burn wounds, and acetic acid 0.5% remains an extremely useful material for dressing burn wounds affected by Pseudomonas. And the reason for that is Pseudomonas detests an acidic environment. Disadvantages are that it requires frequent application because the acidity only lasts for a short time. And if you're going to apply it, then possibly using an irrigation system where you put in some form of cannula into the dressing and have the staff infuse a dilute solution of vinegar into the dressing is a useful system. And that irrigation systems are very helpful for dressings of infected wounds where you perhaps don't have the resources to change the dressing frequently, or it's very painful for the patient to have the dressing changed frequently. But interestingly, I was looking through just immediately before this talk, and I found from the National Institute of Health Research in the United Kingdom, this study, which was from another superb burns unit in the UK, Queen Elizabeth University Hospital in Birmingham, acetic acid as a novel therapeutic agent in traumatic and burn wound infection. So they're actually looking at a scientific study of acetic acid, and there's lots of good literature out there about acetic acid. So I think for units which have, for any unit actually, and I was going to say for limited resources, but for any unit, if you have issues with Pseudomonas, then getting a system that allows you to use 0.5% acetic acid on the wounds is excellent for Pseudomonas. Chlorhexidine is an antiseptic which is very widely used, but mainly used for wound preparation rather than for burns dressings. It does have good activity, but it tends to be deactivated quite quickly. So it's not that popular for actual use as a burns dressing. But if you have nothing else, then 0.5 chlorhexidine is a very useful burns dressing as well. Stronger concentrations than 0.5% are quite toxic to cells. So again, the concentration is very, very important. So this is just revisiting sodium hypochlorite, which I mentioned at the start about that paper from Galveston. There's good evidence for 0.025% solution in the literature being safe for burn wound healing and not impairing with healing, not causing systemic adverse effects. So if people are looking for an inexpensive, readily producible option, then sodium hypochlorite is a very, very useful option. Silver nitrate, again, is an excellent antiseptic and quite widely available. Percentage is very important because at higher percentages than that, it's quite toxic to cells. It has a variety of problems, and the biggest problem is that if it's used on very extensive wounds too often, it can cause methylbugl. So it shouldn't be used on open, excised wounds or on superficial partial thickness wounds that can absorb it easily. It should be reserved for use on full thickness wounds where the skin is obviously dead and is not going to absorb the silver nitrate. Just going to revisit the question and answer again, have a little pause. So, Kieran, I'll just answer your question later. Charles Asiudu, good afternoon, Charles. Nice to hear from you again. Charles is asking about indication for not de-roofing blisters and burns. I think very occasionally in children's hands and feet, where if you don't have facility for good analgesia or anesthesia, then not de-roofing the blisters that are completely intact to avoid pain and distress. But generally speaking, I have always been taught, and all the nurses that I've worked with that I respect have felt the safest thing to do is to de-roof the blisters, because there is always a small risk of getting a pus-filled blister, which creates the potential for nasty infection. Sarah Sabur asking about the short duration of betadine action, meaning we should change the dressings daily when we use it. Certainly, Sarah, if you are treating an infected wound, I would definitely change the dressings with povidone iodine every day. But as a way of preventing excessive colonization, it's a very logical part of a dressing regime which you only changed every 2 or 3 days, just to augment the cleaning of the wound each time in a patient who was well and who was free of infection. So I think the answer to that question, Sarah, is dependent on the clinical scenario for the patient. So other questions, I think, are all things we're going to cover later. So I'm going to carry on with the talk and not answer any of the other questions at the moment, because they'll be revisited later. Unfortunately, this very, very good antiseptic cream, Flamicerium, which is very, very similar in style to silver sulfadiazine, Silvadine, Flamazine. Flamicerium is a superb antiseptic cream in my experience, because it's a combination of silver sulfadiazine and cerium nitrate. And you have this antiseptic, silver sulfadiazine, which is widely used, combined with cerium nitrate. And cerium is a heavy metal ion similar to silver, except it has a particular additional property that's even better than silver, of penetrating and tanning the burn eschar. And what happens is that cerium nitrate penetrates into the burn eschar and it displaces sodium, calcium, and magnesium ions from the compounds in the eschar which are soluble, and it turns them into insoluble salts. And that makes the burn eschar go hard. So unfortunately, it's a perfect antiseptic to use in systems where early burn excision is not available, but it's expensive and it's not widely available in low and middle income countries. But if you're working in a low and middle income country, and you don't have access to immediate burn excision, then this is one product that would be very, very useful. It must not be applied if the patient comes delayed. And there was a question, I'm sorry, I can't remember which of the audience asked, but question about silver sulfadiazine and neutropenia. The issues with neutropenia and silver sulfadiazine and flamacerium are particularly bad if they're applied if the patient comes delayed with infected colonized wounds. So the time to be cautious about using silver sulfadiazine containing products is if the patient comes later with infected wounds. So be more cautious about using them then. Silver sulfadiazine and flamacerium, silver sulfadiazine cerium nitrate, are ideally used very soon after the burn for a few days. I'll just show you a photograph. So this is flamacerium, which has been used on this young woman who had a very severe inhalation injury on a major burn. And this is her limb, her lower limb, about 4 weeks after the injury, with a very solid tanned eschar from the cerium nitrate. And the proponents of it, and there are many in Europe, feel that it allows you to do staged burn excision rather than having to do immediate large excision. So we used it in our practice at Glasgow Royal Infirmary for treatment of elderly, unfit burns patients with full thickness burns, and for people with smoke inhalation injuries on whom we could not do an early excision. So flamacerium, not for use in partial thickness burns, it's for full thickness burns to tan the eschar. I'm sorry for those working in low resource settings to tell you about that, where it's something that you may not be able to source, but maybe in future you can source it. So these are great dressings, silver impregnated dressings, widely used in high income settings. Acticoat is the most typical one. They have a long duration of action. They have a good safety record in clinical practice, but they are expensive. So the advantages of them, they use nanocrystalline silver, which is very, very good antiseptic, and accordingly it keeps the wounds very, very clean. They come in formats that allow good drainage of exudate, but the limitation on their use is their expense. But very, very good products. Most of them need to be soaked in water before they're used. Not all of them, but most of them. Moving on to some more specific types of topical materials. For overgranulation, we tend to use things which contain steroid, but also concentrated silver nitrate can be used for overgranulation. So these are some of the UK products which are used for treatment of overgranulations in burns. So this is traditional burn wound management, and this picture leads on to debriding agent, which is the subject at the moment in burns. And it sort of partly answers Kieran's question about honey dressings from the Q&A. And also a question that someone else had asked, and maybe Kieran as well, about Usol. So typical debriding agent, which has been used in Europe up till about 40 years ago, and widely used in limited resource settings around the world still, is Edinburgh University solution of lime, Usol, which is an alkaline debriding agent. So it's a superb antiseptic. It kills everything, but it is painful and it is very toxic to cells. So it's a classic material where you're putting on a fairly toxic antiseptic chemical that will debride a wound well, but will impair healing. So that's the sort of situation with Usol. So I think surgeons like Usol around the world. We don't use it at all in UK now because it's so toxic to healing. But if you have small infected full thickness wounds which need to be debrided, it works. And if the problem occurs when it's used on and on and on, and then it does cause overgranulation and pain and impairs healing. So probably the way to use Usol is for a short burst to get rid of infection and to get rid of necrotic tissue, and then change to a more a wound healing type dressing. Moving on to honey. Now, honey is already widely used, but has huge potential for use around the world because it is an agent which does, because of its osmotic effect, it prevents infection and debrides necrosis, but it does not impair epithelialization to the same extent that most other strong antiseptic or debriding agents do. So in answer to the question from Kieran, honey, I think, is a very, very useful agent for small burns. And a few years ago, I saw a presentation from the big unit at Baragwanath in Johannesburg in South Africa about how they were using it on quite large burns as an early dressing for deep partial thickness burns. The difficulty is that it's, even in the limited resource setting where it might be widely available, it's quite hard to use on large wounds. And it tends to be mainly useful for small wounds. Although it's cheaper than a lot of things that are available, to use it on large wounds is expensive and is difficult. But certainly for treating smaller burns where you have necrosis, a bit of infection, but you want to also enhance epithelialization, honey is an excellent thing, and it's now widely used in high-income settings. There's just a reference which you'll get from the PDF of the presentation about topical application of honey for burn wound treatment. The most topical and quite exciting development about debriding agents is Nexabrib, which is a bromelain type enzyme, which I think is derived from pineapple originally, developed by an Israeli innovator and then company, and now widely used around the world for enzymatic debridement of partial thickness burn wounds. So the primary indication is for mixed superficial to partial thickness to deep partial thickness burn wounds. And the emphasis of use of Nexabrib is that it may selectively debride necrotic tissue, leaving viable tissue behind for healing. My take on it, from a purely personal prejudice point of view, is that for widespread use, it remains relatively expensive and it tends to be painful for the patients. So its rational use is based on having very good pain management protocols associated with its use to prevent pain for the patients, and on the fact that as it's relatively expensive, the cost effectiveness studies on it are done by comparing the cost of using Nexabrib against the cost of excision and skin graft surgery. So for people working in limited resource settings, it looks very good on the surface, and there's very, very high quality literature about its use. But how much difference it's not really been proven to make huge difference to outcomes yet. And the theoretical advantage of it is that it may reduce the need for skin grafting and that it may therefore enhance outcomes. But as far as that's concerned, the jury is out. It probably reduces the need for excision and debridement, but for deeper wounds treated with Nexabrib, they still have to be skin grafted. And for more superficial wounds, commonly they recommend using biological dressings with it, and the biological dressings are quite expensive. So it's a exciting development, but it's not yet clear just how good an indication it is for people working in limited resource settings. I'm just again going to visit the questions. Any recommendations regarding dressings for facial burns from Helena Legesi? I'll talk about that a little bit more about specific dressings, Selena. And I'll talk about hydrocolloid dressings, Mohammed, Kieran. Best way to dress the hand. That's a very, very good question, Kieran. And what we do in our practice is we dress the fingers individually using little gauze, tubular gauze dressings, which are non-constricting, so that the person can use their hand. Obviously, the other historical typical option is dressing the hand in polythene bags with antiseptic in the bag, but you get terrible problems with maceration of the normal skin and it getting very soggy. So we have this tubular gauze dressing, which is called Tubinet, that you apply with a little metal applicator for all the digits to allow the fingers to move. Salma El Hussein's asking about using flamazine in pediatrics. I think it's around the world, it could be a mainstay for pediatric burns, really, because most pediatric burns are scalds, which are partial thickness, and flamazine is excellent antiseptic, well tolerated, comfortable for pediatric burns. And I feel if I was running a burn service in a limited resource setting, I would tend to reserve the flamazine for the children with partial thickness scalds and treat them for the first week or two with it, changing it as seldom as possible to be sparing about using the amount of flamazine because it's fairly expensive in a limited resource setting. But I think flamazine for pediatric burns is excellent. Mohammed, I'll answer a question about hydrocolloid later, and we'll talk about facial burns later, okay? So I'm just going to carry on now. Excuse me while I was just answering the question and answer. So carrying on with simple dressings, I think you all know this, so I won't labor it, but tuiles are just the basic dressings that we use. Ideally, the tuile, as the primary dressing on the wound, ideally the tuile should not stick to the wound, but we all know that they do tend to stick. It's a mesh gauze which is impregnated with white petroleum gel, which also goes under the names Vaseline and white paraffin. So that's our classic, widely used dressings. And we use it because it's cheap and it's easy to make and it's widely available. And again, this isn't what we use for our major burns. For our major burns, we have it coming in a roll or in huge sheets, which we use. More expensive versions of tuiles for the primary dressing are silicone mesh dressings, and these are very good, but in our practice, even having a lot of resources, we don't use these very much. We mainly reserve these for children because they are expensive. So for our adults, we use the typical paraffin gauze, and we reserve the silicone mesh dressings, but silicone is probably superior to paraffin gauze in terms of not being as adherent, and that's its big advantage for children. So I'll just run through that. So talking now about hydrocolloids, one of the questioners asked about hydrocolloids, and there you see at the top some types of hydrocolloid dressings. They are very nice dressings for small wounds, and they are excellent, as one of the people in the questions asked about pain relief, that they do give pain relief. Disadvantage of hydrocolloids for burns in most settings is that they are a problem on infected wounds. So you can only really use them happily on thin, or on small non-infected wounds. They had been very popular for use on facial burns. And so one of the questioners was asking about management of facial burns. And it's a really, really superb question, because I spent 37 years working in burn care, and I never yet found a good treatment for facial burns. But our mainstay of treatment for facial burns was exposure and application of topical antiseptics if necessary, but generally just application of oils to soften the sort of superficial eschar that forms on the facial burns. But if you want to dress facial burns and they're clean, then hydrocolloids, thin hydrocolloid dressings, are the type of dressing which has been shown to be most effective for superficial facial burns, but they are not good for deep burns. So bottom line for facial burns is there's still no perfect solution, and most services around the world use exposure. So my apologies. So there's a brand of hydrocolloid, Duoderm, which you see there. There are a whole variety. You don't have to use Duoderm. There are a whole variety of different brands, but they do. They're the classic dressing which promotes pain relief and good epithelialization by creating a moist environment. But the problem in burns is that moist environment also facilitates infection. So one of the questioners asked before about hydrogels, and hydrogels are gel dressings which contain a lot of water, and they are the classic dressing which is very good for reducing pain. And I know this because my son was in a summer job. He got a petrol burn to his face and had terrible pain. And the only thing that helped was when I went to the chemist and bought a hydrogel dressing and put it on his face. So they are now marketed in high-income countries, hydrogels, actually for first aid after major burns, as a way of cooling the surface of the wound and reducing pain. They are also very useful for use on dry necrotic wounds as debriding agents. And one of my colleagues at the Glasgow Royal Burns Unit, the Canisburn Burns Unit, is very keen on using them for that. But again, they're not something that you use widely for large major burn wounds. But the typical things with hydrogel are reduction of pain, and that they soften dry necrotic wounds. And there's some types of hydrogels that are available. They can come in tube gel forms or sheet form. So in answer to Kieran's question about donor sites, I'm now going to talk about fibrous polymer dressings. So fibrous polymer dressings, most widely used ones are alginate dressings, which are commonly derived from algae or seaweeds. And they're used on wounds that have a significant exudate, and they can be silver impregnated. And there's quite a good product that's a silver impregnated one. So the typical fibrous polymer dressings are Caltostat, Sorbicen, or Aquacel, which can be impregnated with silver. And I went through a phase of using Aquacel with silver on major excised burn wounds along with the skin grafts or allografts, and we found it very, very effective. But these are relatively expensive dressings. Caltostat is less expensive, alginate dressing derived from seaweed, and we use it widely for donor sites. So in answer to the question from Kieran about wet or dry treatment of donor sites, I think it's a very good question, Kieran, because we would generally try and treat a donor site dry with alginate dressing like this. except we would put some local anesthetic on it to reduce pain. So that's bupivacaine being sprinkled onto this donor site dressing. So if you have a small or small-ish donor site, then using an alginate type dressing is superb. And although you put some local anesthetic on initially, it basically works as a dry dressing on the donor site. And what happens is you leave it on for about 2 weeks and it dries out and then it lifts off easily. However, and this is where the question, do you use donor sites dry or wet? In a really big major burn donor site, I found that using this dressing, it just gets really soaked and it doesn't work so well. And it sometimes ends up like just a great big lump of culture medium for bacteria against the patient's donor site. So in major burns, more often I went back to using just a tulle with a wet dressing as the base layers, and then lots and lots of padding to absorb on the top. So I hope that answers the question about donor sites. Again, no absolute clean-cut rules, and it depends on the patient. But if you have a facility to have a relatively dry donor site, then these alginate dressings are absolutely superb. And the advantage of them is they don't stick into the surface of the healed donor site in the way that a tulle does. You know how you get the tulle with the pattern of the mesh that gets almost integrated into the donor site sometimes. That can cause a problems, whereas the alginate dressings don't. So I hope that answers the question about donor sites. So I'm just going to quickly look at the questions again.
I think there's the one about donor sites asking, which you just answered, about whether or not you'd put Gelinet on donor sites.
Yeah. So I use Gelinet on donor sites for major burns where you've got a really big donor site, and I use anything slightly smaller. I use the alginates. I'll just carry on. I shall look at the questions again for a little bit. So Sarah Amin asking about overgranulating burn wound. Yeah, Sarah, so our treatment, I'll just go back to the slide for Sarah Amin, if that's okay for everyone. Yeah, so for overgranulating burn wounds, mainly steroid-containing products are what you would use. So something with hydrocortisone, and these are commercially available things from Europe, Terracortrol or Fusidin H, but mainly steroid is what you'd use for overgranulating burn wounds.
I think Tarak's asking if you'd ever intervene surgically to excise overgranulation.
Definitely, definitely, and I think that's a good point. Sorry, I won't labour that because we're mainly talking about dressings, but yes. So most of the other things I will answer later in the talk, so I'll just carry on. So human amniotic membrane is something which I've been interested in reading about for all my career, but never used. But in some countries, in low-income centres, low-income countries, centres in low-income countries, has been widely used. And it has, one of the questioners is asking about amniotic membrane for facial burns, and in many ways it would be a perfect dressing for facial burns if you had access for it, and it fulfills all the requirements. It would conform very well to the surface, it would gently adhere, it would reduce pain, it would control infection, and it would stimulate healing. So the main issue with amniotic membrane is getting a service to actually source it. So it can be sourced relatively inexpensively. but you do need a team who are going to work on that and who have the initiative to do it. So it has huge potential for treatment of partial thickness burns and for temporarily covering excised wounds, but it's actually getting it, it's actually sourcing it that there's the issue. And I'm not sure if it does need to be changed daily. I'd need to, that's what I read, but I'm not entirely sure. Can be stored for longer. Issue is it requires virus testing. So has huge potential in a limited resource setting in terms of massive potential availability, but you do need the actual system to source it. So that's the issue with amniotic membrane, but it's there as a potential. Porcine skin is not similar to amniotic membrane. It's not as, I don't think from the reports that it's as good as amniotic membrane, but it is hugely widely available and very inexpensive potentially. And we're thinking about some sort of biological short-term skin substitute. But there are a lot of religious sensitivities about using it. And it's one of these things that if it does get infected, then things tend to go badly. So it's needs to be used with caution if you do use it. However, pigskin is basically the basis for a very widely used high-tech dressing called BioBrain, which is made of porcine collagen with silicone in it, and a surface nylon layer. And this comes into the category of skin substitutes. And the pictures I have are of use of BioBrain for treatment of partial thickness burns. And one of the questioners has asked about the use of collagen. So I'll just talk through, if the questioner who's asked about the use of collagen, assume that the answers are for BioBrain 2, the answers from BioBrain apply to collagen 2, also to pig skin, also to a lesser extent amniotic membrane, although you need to change amniotic membrane more often. But BioBrain is a synthetic product which is derived from pig collagen. It's very useful on superficial partial thickness burns in children, and that's its great use. So here's a child with a superficial partial thickness burn, a reasonable size, and once it's been debrided, the BioBrain is applied, and it adheres like a second skin. And that when we're thinking about skin substitutes used as dressings, people describe them as functioning like a second skin. So this is this BioBrain dressing, and this is about 6 days after it's been applied, when you see the more superficial bits of burn around the edge have healed completely, and the superficial partial thickness burns have this adherent surface. So as long as you apply BioBrain or other skin substitutes very early after the burn, then you get an adherence to the burn and a prevention of infection and reduction of pain. So this is just a diagram of what the BioBrain is like. Silicone on the outside, collagen in the middle, silicone mesh with a nylon waterproofing layer on the outside, and collagen in the interstices, and it sticks to the surface of the exposed dermis. So it temporarily integrates onto the surface of the exposed dermis to reduce pain. And other similar materials are Suprathel, which is a wholly synthetic polymer dressing, which has been found widely used in Europe, lesser used in UK. And again, it adheres to dermal burn wounds, reduces pain, facilitates healing. Epicyte, a cellulose type dressing that's used. And these are some other examples. So for example, in answer to the question about the use of collagen, I spoke to colleagues from Indore in India who use bovine collagen on painful partial thickness burn wounds such as the face, or on excised burn wounds. So there's definite potential use for collagen on clean dermal burn wounds, which are very painful. Tilapia skin has its proponents around the world, and these are more historical, very expensive American products, Transite and Dermagraft, which were allograft derived. So these are some other skin substitutes. The problem, going back to the BioBrain, is all of these things are relatively expensive, and they kind of have a sort of niche role for management of painful burn wounds to reduce pain. Negative pressure wound management has its proponents for burn wounds, in children particularly. I think it's fair to say that there's not universal literature to support its widespread use, and I would tend to reserve it maybe for very small, very difficult, excised, very deep burn wound, and wouldn't use it widely for burn wounds. So just to conclude, that's a summary of a lot of the widely available methods for dressings, and I'm just going to revisit the questions. Thank you all for your attention. I hope that wasn't too tedious going through a non-surgical subject. So, Sarah, an answer to your question about the tubular gauze, the one we have in UK is called Tubi gauze, but if you can imagine, it would be relatively easy to design. You have this little metal cage that you put over the finger with the gauze rolled up on the outside, and you put it up and down to put on layers of the gauze, and then you cut the tube of gauze off. And next question, roles of BTM and theragenesis. So Kieran, the answer to the question about the role of BTM, that's on excised burn wounds, and the evidence is that BTM is superb on excised burn wounds. And I'm really sorry, please excuse my ignorance, I don't know what theragenesis is. Tony, do you know what theragenesis is that Kieran was asking about?
I'm afraid I've never heard of it either, so no, can't help there.
Sorry, I'm sorry about that, Kieran. I suspect it's a product that you get that we don't get. Question from Abdullah. In resource-limited settings, my take on the feasibility of early excision and grafting. So the key things, Abdullah, for early excision and grafting are start with extremities that you can treat under tourniquet so that you minimize blood loss. Make sure you have good anesthesia and theatre nursing and ward nursing support. But particularly those things in terms of early excision and grafting. So don't do difficult areas on the trunk and shoulders and axilla, but stick to extremities like the hand and the foot, where you can control bleeding by tourniquet and by elevation, because it's a challenge if you've got limited resources. Oh yes, sorry, Nagla Mohammed, this is a great question. Special topical dressing treatment for ear burns, and I'm really sorry, I missed something out. I knew there was something I'd missed out, and so I'm so glad that you asked this question. It's sulfamylon, which is the trade name for mafenide acetate, which is a antiseptic which has been widely used for burns in North America, is sort of felt to be the best treatment for burn wounds, but we can't get it in UK. And so I've never used it, but I was going to mention sulfamylon, mafenide, because it is renowned for being excellent for ear burns because it penetrates into the surface of the burn wound better than just about any other antiseptic. What would I use? I would use iodine frequently on ear burns. If I had some sort of iodine, povidone iodine ointment preparation, I would use that on ear burns. If I was worried about a Pseudomonas infection on an ear burn, I would use silver sulfadiazine, and I'd give systemic antibiotics. So in the ears, if you're worried about an infected ear burn, have a low threshold for systemic antibiotics, either anti-staphylococcal in the early stages or anti-Pseudomonas later. Very good question for Elena Pascu about autologous cell-laden hydrogels in the future of large body surface area burns. I think there's no question that finding some sort of dressing skin substitute, which is a carrier for autologous stem cells, is a future innovation that will enhance burn results. Question from Dr. Luis Cabral about chitosan dressings. I'm really sorry, Dr. Cabral, I don't know chitosan dressings for donor sites. That's probably an international thing. Tony, do you know the chitosan dressings that Dr. Cabral is asking about?
No, I don't, but I've just found out from one of the other people that the thermogenesis is essentially, I think, Integra.
Okay.
But I don't know about this one, no.
Okay. So that so Goran Jovic from Zambia, hi Goran, is asking about leaving donor sites exposed. The only time I've done this, Goran, is for scalp burns, where it's more manageable, sorry, for scalp donor sites, where it's more manageable to leave it exposed. We always find the problem with leaving donor sites exposed is the pain for the mobility of the patient. So it's an excellent treatment if you have a site that can be left completely alone, and the scalp does to some extent fulfill that. But even then, the person can rub their head on the pillow, etc. So I know that leaving donor sites exposed has been widely used in the past with great success in North America, and just painting the surface with antiseptics, but it's not something that we've used. Sophia Papadopoulou has asked about tules with chlorhexidine, Bactigra, and that's widely used for small burns. It isn't something that we commonly used. We tended to more often just use a simple antiseptic in the actual gauze. Very good point here from Dr. Tanvir Ahmed for relevance for limited resource settings of using melalin for small and mid-sized donor sites. And the other thing that people have used widely is sterile Hypofix for donor sites, which is a very, very good donor site dressing if you had limited resource and you have access to Hypofix. So I've shown the things that are commonly available in UK, but that's a good suggestion for a way of using that dry donor site principle that I showed with the alginate, is using melalin for that, which is very inexpensive. Charles Asiudu from Ghana asking about BioBrain and Opsite dressings. So Charles, BioBrain has some properties of the ideal wound dressing. The problem is if you get any exudate collecting under BioBrain, it creates the potential for like a little abscess. So if you use BioBrain, you have to be very, very careful about it sticking to the surface of the wound. And if you put it on a deep wound, then the necrotic skin in the deep wound lifts it off. And again, you get the potential for infection underneath. So I think BioBrain is ideal on a superficial wound where you're emphasizing control of pain, and control of exudate by sticking like a second skin, but it does not work on deeper wounds, and it does not work in the presence of infection. And the other question I think Charles asked was about opsite. My experience with opsite is it's not permeable enough to use on donor sites or burn wounds, and it just gathers. The opsite, for those people who are not familiar with the specific product, is it's a transparent adhesive film dressing, and it basically just collects a lot of fluid underneath it on an exudated wound. Very good question about fish skin, and I'm sorry, I don't have experience with fish skin, but the literature from tilapia skin and fish skin suggests that they may be very useful products for partial thickness burn wounds and temporary cover of excised burn wounds. But my experience of looking into them is they're not as cheap as one would like them to be. So I think the theoretical advantage to me of fish skins would be that they'd be inexpensive, but even for our practice working in United Kingdom, they seem relatively expensive for what they are.
That's one I can sort of come in on, because actually we were given some to trial, and we only had enough for a lady where we could do one of her legs and not the other, and we did the worst leg, and actually it healed quicker. So but we also thought it was too expensive, so I'm not sure we'll be using it in the long run, but my experience was positive.
Yeah, they definitely seem like good products. Thanks, Tony, that's really helpful, because people may want to check before they use them. So I think the literature, and it's good to have a specific experience there from Tony about them, is positive. Do you think it's similar to BioBrain in terms of its use, Tony?
Yeah, I think this sort of falls into the same bracket as what you'd use BioBrain for, I think.
Thank you.
Yeah.
Question from Ramesh about dressings for tracheostomy site in inhalational burns. That's a really good question, because tracheostomy sites and burns are quite a trouble. I would say, to take your question one step back, sort of like a politician, Ramesh, first thing I try to do in the burns patient is to make the tracheostomy incision as small as I can. And that usually means doing it through a small vertical incision rather than a transverse incision. And then early on, we just use a simple foam dressing to protect the skin around it. But later, if there's problems with healing, I found just not really packing the wound very hard, but packing the wound a little bit with old-fashioned ribbon gauze soaked in antiseptic. So just very gently packing it around the tracheal tube, and then just letting that gradually heal up, so that it kind of fills the dead space a little bit with gentle packing, but not vigorous packing, just very gentle. I hope that helps. Also, in the burns patients, I always tended to supplement the fixation of the tube with some quite solid sutures as well as the tapes, because the tapes get very dirty in the burn wounds, and it means that they can change the tapes more readily, and there's less risk of the tube coming out. Question from anonymous attendee about downside of using VAC on fully excised, full thickness burns. The only downside really, colleague, is the VAC's just moderately expensive, and if you've excised the burn, you really just want to be getting it skin grafted to getting it healed up rather than vaccing it. And then if you skin graft it, yes, there's some anecdotal literature suggesting that you get better skin graft take under vax, and some people are very keen, but I think a careful conventional dressing on a skin graft is just as good as most VACs. Exceptions to that are using skin substitutes such as Integra or BTM in difficult sites such as the axilla, the neck, and the breast, where I think it's worth trying to use a negative pressure dressing to get the skin substitute to take on an excised wound. But my main issue with the VAC is the expense of the application isn't always justified. Question for Abbott Michael Araha. Thank you, Michael, about using honey for diabetic patients. Yes, as far as I know, I've definitely used honey for diabetic patients with problematic wounds and seemed very, very good for the combination of necrosis and infection that you get in diabetic wounds. Question from Alexandru again about fish collagen dressing on major burns. I don't know about European and North American studies for that. The studies I've seen are from Brazil, Central America, which were quite good studies, so I'm not sure. Mohammed Abdelati, great question about MEBO. Moisture, a really good question to raise because I have no experience on MEBO, and I should have mentioned MEBO in the talk. But MEBO is widely used in China and the Far East, and it is claimed to both debride burn wounds and enhance healing. The claims that one sees about it and the papers I've seen presented seem dramatically good in terms of its use. Quite why it hasn't, if it was as good as that, it hasn't spread more around the world, I don't know, because it's been around a long time. So I'm thinking that perhaps people who've tried to apply it in other settings have not found it was as good, but I don't know that. So thanks for the question about MEBO. It's used in a lot of people's burn wounds in the East, and people claim great success for it, but I'm not sure. Thanks, Dr. Cabral. I'm sorry, we don't know the chitosan dressing. I don't know, Dr. Cabral, if you just maybe put another comment on the Q&A for the audience so that they know how it works, because we're not familiar with that. I'm sorry. Thank you.
There is a question that came up in the chat about use of putting burnt hands into plastic bags. I presume they mean with dressings in it. Do you favor that?
No, a long time ago when I started, we used to use that, and it's very good for mobility and it's quite good for comfort of the patient, but the wounds get terribly macerated and soggy, and we found that we didn't believe it really facilitated healing because they were so soggy and we had to change them so much. So I more favor the individual dressings of the digits and a nice hand dressing rather than using the bags. What's your view, Tony? Would you, if you were dressing burns, would you use the bags? They're still a very reputable way of treating them, and they were the standard care for a long time.
Well, having heard your comments, I will now be dressing them rather than using bags. I don't do nearly as much burns as you, so I would.
I think it maybe depends. I think if you use the bags and you change them really often and you use antiseptic in the bags, then they don't get so macerated.
Yeah.
But then when the hand is exposed, it dries out and it gets sore, so it's not so good.
Yeah.
So question from Sarah Sabur, in your settings, did the nurse change the dressings for the patients or the surgeons? So Sarah, mainly the nurses do the dressings with us, and in in the adults, almost all the dressings are done in the burns unit with analgesia, which is sometimes intravenous analgesia, but usually oral analgesia and distraction. And the children, more often the dressings are changed in the operating theatre, and they're usually changed by the surgeons because there aren't so many nurses in our children facility. But sometimes the specialist nurse would come and change them. So just the more often adults in the burns unit with analgesia, children in theatre. Question from Paul Gill from Trinidad. Hi, Paul. Thanks for joining us. I don't know zinc oxide for burn wound dressings. Sorry. I guess it probably acts as an occlusive paste, which is probably quite comfortable, but mainly maybe just for small dressings, is it? But I don't know, I'm sorry. Monimang Modis Ketili asking about honey dressings on radiation therapy burn wounds. I'm not sure. I probably wouldn't use we don't see very many radiation burns here now, but honey just in very superficial wounds, which radiation therapy burn wounds usually are, at least very painful wounds. Sometimes honey, because of its osmotic effect, can be really quite painful. And I feel it's better on deep wounds that have some necrosis and infection that needs debrided. Whereas the radiation therapy burn wounds tend to be quite superficial, and we're focusing more on pain management. So as long as they're not infected, I would use hydrogel or hydrocolloid or a simple dressing. Ahmed Eldali, after skin grafting, what dressing is best to be applied? Ahmed, we usually use tulle dressing, paraffin gauze, and then a simple gauze, and then wool, and then a crepe bandage and a splint to immobilize the area. In the children, we use the silicone mesh dressings, by preference over the tulle, because they adhere less in the children and you can leave them on longer. And a couple of the audience have been asking about use of negative pressure dressings. Some surgeons recommend negative pressure dressings with skin grafts in difficult sites, but I rarely use them, not often, very seldom use them. So most of what I would use are adults, tulle, paraffin gauze, and then children, silicone mesh dressing, and then covered with simple dressings. For difficult sites, I like using an old-fashioned tie-over dressing, just made of gauze or wool soaked in aquaflavine or proflavine or some other antiseptic. Very good question from anonymous attendee about enzymatic wound debridement. I think you can use simple dressings after enzymatic wound debridement. Definitely, I've asked colleagues about that, but most of the colleagues that I've spoken to about enzymatic wound debridements, they do prefer biological dressings. So I think it depends on preference and on the individual unit. But the problem is that you have exposed dermis, which can desiccate if it's then left exposed with a simple dressing. So after use of Nexobrid for enzymatic debridement, mostly people seem to recommend biological dressing to prevent further desiccation and necrosis of the dermis. So Dr. Cabral has come back to say he's used chitosan dressing in donor sites with good results in terms of pain removal. So that's something for people to look out for if they have the access to the chitosan dressing. Thank you. Mekanon Abebi a question about combining honey with ghee to minimize pain. Absolutely, and this is like the one of the lessons of history that we learned from about dressings is combining simple ingredients. So if you use a ghee which is suitably sterile along with an appropriate honey and in a chule, then you've made a antiseptic non-adhesive dressing. So that is basically where chules come from. And for example, the burns unit I work with in Blantyre in Malawi, they've made up their own chules there with just using the gauze and the paraffin gel. So this is it's a great principle that you can, if you have the appropriate ingredients, you can make your own things. So Aya Mohammed Hassan El Hag Yusuf, thank you for the question. Usual frequency of dressing in unit for clean versus infected burn wounds. So I'll answer this as simply as I can, Aya. Infected burn wounds, if possible, dress daily. And if you have a Pseudomonas infection, use acetic acid 0.5% and use an irrigation system to put into the dressing. Clean wound, if it's a full thickness burn, I would change the dressing every 2 days and use an antiseptic on it. If it's a superficial clean wound, we would change it every 2 days initially, and then later, if the patient is well and it's a superficial wound, I would try and leave it every 3 to 4 days and use a more sophisticated dressing on it of some kind, maybe something impregnated with silver, or if it's a small wound, a dressing such as a hydrocolloid or a hydrogel to facilitate healing. So bottom line is, cleaner the wound is, the longer you leave the dressing on, as long as the patient is well, especially with small wounds. The more infected the wound is, the more frequently you change it. Oh, very good question, actually, about another anonymous attendee about Prontazan. Yes, I'm sorry, I should have said we use Prontazan, which is a very gentle soapy antiseptic for cleaning of facial burn wounds in children. So that's a really good point. And thank you to several questioners who've identified things that I've missed out. But Prontazan is a product which is available in UK. I'm not sure where else. That is a gentle soapy antiseptic that is very is a good, because it's slightly soapy, it cleanses wounds, but it doesn't cause a lot of pain and it doesn't cause cellular necrosis. And I'm sorry, I'm not familiar with microdacin, but I'm guessing it's a kind of Dakin solution with hypochlorite. So basically, yes, we occasionally use sodium hypochlorite. And as I said, the best burns unit that I know in UK, in Chelmsford, uses sodium hypochlorite. So definitely consider using appropriate strength sodium hypochlorite agents. I think that's all the questions.
Great, thank you very much. I think that is all the questions that are answered. And I think we've picked up the ones from the chat. So it just lands to me to thank you very much for giving this amazing talk, Mr. Watson. I think we topped out at 216 attendees at one point, which in this post-pandemic era of webinar fatigue is excellent, because I was a little bit worried about what the turnout would be. Mr. Watson has very kindly agreed to 2 further talks. He is due to give a talk on the 17th of, so both of them are Saturdays at 1 p.m. again, the 17th of February. The title of that will be The Basic Principles of Flap Design and Technical Tips, which I'm sure will be equally useful. And the 19th of March is Choosing Flaps for Common Defects. Again, I saw I mean, some amazing local flaps, which I would never have considered using, which you gave in your talk in the Gillies lecture. So I imagine we'll be treated to some really fantastic ideas for treating wounds, particularly in LMIC settings, because what it showed to me was actually we often forget about some of the more basic stuff in plastic surgery, particularly in the countries we're lucky enough to work in, and jumping straight to free flaps when actually there are very good local flap options. So I think these will be two other excellent talks to attend. Hopefully we'll have as many people attending as we have today, from stretching from Bhutan right the way through to Peru. Lots of people from Africa joining us: Nigeria, Liberia, Zambia, Ghana, Malawi, and interestingly, a whole bunch of you from Kimberley in South Africa. I'd love to know if someone wants to add in the group why so many of you from Kimberley joined us and how you heard about it. But thank you very much, Mr. Watson.
Can I just quickly say, Tony, I thank you to all the participants in joining. I'm humbled and privileged to have so many people from so many different places join, and I hope the talk was of use. And as I said at the start, if everyone just email the BFIRST group just to check if you wish to get the PDF of the slides, that's available, and you can have all the slides, because I just want to say that this Dr. Muhibullah Bangash, he very kindly had put a PowerPoint on the internet for other people to access. So some of the slides about the less common dressings, most of the talk is mine, but some of the slides about the less common dressings that I didn't know so much about are his slides. So I just want to thank him. And I think it's the way that some people put their material out there for us to use. So thanks to all the audience for joining. I really appreciate it.
Yeah, so as well as trying to get the PDFs out to you, this will be available in a few days' time on the BFIRST YouTube channel. I should just say that if you wanted more information about the BFIRST charity, then the website is www.bfirst.org.uk. You can find about projects that are going on. We have just closed our fellowship program for this year. So, but if you wanted to be considered, that's involving people coming to the UK to study in more depth, then please do apply for it. You'll find details for that on the website. And should you be interested in possibly having a visit or a teaching program set up in your unit, you can contact us via the website. Again, the email address is bfirst.info@gmail.com, but all can be found through the website. Thank you very much for attending. Hopefully see a lot of you on the 17th of February. Take care. Bye-bye.